Good evening. Thank you so much for joining us. I think we'll kick off now. We're delighted that so many people showed such a lot of interest in registering for this event and then sending lots of questions in advance. Dr. Clare and I are passionate about empowering women with knowledge and advice on all things menopause. And obviously, a key part of knowledge and empowerment is understanding the treatment options that can help you take control and manage your symptoms so that you can thrive in this stage of life. So in this evening's webinar, Dr. Clare, who is my really good friend, co-founder of My Menopause Centre, where she's also clinical director. Claire's also a registered menopause specialist and GP. She's a GP partner in Leeds, where she also runs a very big NHS menopause clinic. And I honestly think there isn't anything about menopause and HRT and any other treatment option that Clare doesn't know. So it's brilliant that we can tap into Clare's vast wealth of experience and expertise in this evening's event. We'll be covering off a whole range of things around HRT. So we're going to we'll start off by looking at what it is. We look at the benefits, we look at the risks, we look at the side effects. Clare's also going to show us the different types, what it looks like, so you can see how to apply it. We look at the most common myths. We also cover prescribable alternatives to HRT, particularly for those who can't or don't want to take it. And then Clare will also cover the questions that she most frequently gets asked by her patients. And then I would say, pop your questions into the chat as we go through. We'll either weave them in or come to them at the beginning. And again, thank you to those who submitted them in advance. And again, we've woven those into the conversation. The webinar is being recorded, so we'll share it online later on this week. And remember that we're fortunately not permitted to provide any personal medical advice within this session, but we can, of course, comment on general questions. And also remember, you should always talk to your medical professional before acting on any information provided. So, Clare, let's kick off then. Could you explain to us what HRT, hormone replacement therapy, is and what happens to our bodies when we take it?
Yes, good evening, everybody. It's so great to see everybody with us this evening. So I think in explaining what hormone replacement therapy or HRT is, it's worth just stepping back and just think about what's happening as we transition through the menopause. And the key thing to know is that estrogen, which is one of the most important hormones made by our ovaries, in the menopause transition changes from a lovely rhythmical up and down every month that gives us a regular cycle for most of us, to an erratic up and down in the perimenopause, where the troughs are deeper than they were before the menopause. And then ultimately, as periods stop, as we enter the menopause itself, the estrogen levels are low and they stay low. So you've got erratic changes with deeper troughs in the perimenopause, and then that very low level post-menopause and beyond for the rest of our life. So hormone replacement therapy is fundamentally aiming to fill in the deepest dips of those dips, and then just lift our level at a constant higher level in the post-menopause. So although you can fluctuate before the menopause from, say, levels of 200 to 2000 and back again, HRT doesn't aim to get you back to 2000. It's just aiming to give a constant low level, enough to be able to manage the symptoms that we experience because our estrogen level is low and fluctuating.
Super, thank you, Clare. It's just good to have that context, isn't it? And of course, there are different types of hormones that we're talking about in hormone replacement therapy. And there are different ways that each of these can be prescribed and taken then. So it would be great if you could kind of give us that overview of the key hormones in hormone replacement therapy and the different ways of applying them. And when you're chatting to your patients, what leads you to recommend or somebody to decide which one is best for them?
No, absolutely. So let's start with estrogen, and then we'll come on to the other hormones in a second. So as I said, the key is the estrogen. Now, the first choice is usually estrogen through the skin, which is called transdermally applied estrogen, because this has no additional risk of blood clots on legs, lungs, and stroke, Whereas if you swallow estrogen tablets, it does increase your risk by a small amount. So transdermal estrogen comes in a gel form. This is estrogel or little sachets of Sandrina. And this is good because you apply it every day. So it means you don't have to forget, or well, something, you know, it's not, you can get into a routine with it. Estrogel is what I commonly prescribe, and you put 1 dollop onto the palm of your hand as 1 dose, rub it down the back of your arm or your inner thigh, it doesn't matter which. Sandrina little sachets come individually wrapped, and you make a little hole in it, tear the corner off, and again rub it back of your arm or thigh. I like estrogel because I can say start with 1 pump measure a day and increase it up if you're tolerating it. But say you're still having a few hot flushes, after 6 to 8 weeks, you can increase it to 2 pump measures a day. So I like this because it's you can control it. And it sort of doesn't feel like you're taking a tablet or you're taking medicine for women who don't like taking medication. So that's estrogel. Patches are really good. So this is an estrogen patch here that you stick on your body in a, I usually say in a generous bikini bottom distribution. So top of thigh, bottom, lower tummy. Patches generally are changed twice weekly. So that's after 3 days, then 4 days, 3 days, 4 days. So it's always the same day. There are some weekly patches around. I tend not to prescribe them too often because they tend, if anything's going to fall off, the weekly patches are likely to. You can swim, bath, shower, exercise. They shouldn't fall off. I am not going to lie. Occasionally they do, particularly sweaty lycra can just rub the corners off if you're, say, running or exercising vigorously. But otherwise, the positive of these is that you don't have to think about it every single day. It just sits there. The negative is you have to remember to change it. So I usually say, look, just set an alarm on your phone to remind yourself. Okay, patches. There is a spray called Lenzetto, which is liquid estradiol. And you spray this liquid against your forearm. A bit like gel, it's a once a day application. A bit like gel, takes about 5 minutes to dry. There have been issues supplying this where I work in Leeds. That will differ around the country. So this is a good option if you feel like you're coated in gel, drying yourself in the morning, but you want something daily that you apply. And then, of course, there are tablets which are super convenient. So although the risk of blood clots on legs and lungs and stroke is slightly higher, for most women, the risk will still be really low. And literally tablets, you just swallow 1 every day. So that's really straightforward. So that's the estrogen.
Yeah, that's really helpful. And there's a great question in here around why do you have to rub the gel or apply the patch, I guess, in specific places? So with the gel on the arms or thighs, and the patches kind of in the abdomen or thighs as well.
Yeah, and it's because then when a drug is licensed, they have to do lots of studies on the absorption of the drug and blood levels of the drug. And that data is all then presented when applying for the license. So they'll have done the studies on the back of your arm, on your inner thigh to show, and they'll know how well it's absorbed in those areas. It may be absorbed brilliantly from other areas. We just don't know. That's where the data lies, in those areas on your body.
Okay, that's really clear, Claire. Thank you. And again, a related question, again, a very practical one. In applying the gel, how quickly is it absorbed? And say, how long would you have to wait before swimming or doing sweaty exercise so that it doesn't interfere with the absorption?
Yeah, really great question. Rule of thumb, it's 2 hours. So it will dry in about 5 minutes. It dries quite quickly, but then it takes 2 hours for your blood level to peak. So we say stay dry for 2 hours after applying it, if you can.
Yeah, and then a question that we had at the top of the call as well: is it possible to apply or to take too much estrogen?
Oh no, that's a really good question. Yes, you can. So I know I said if you're having periods, there's a really big range of estrogen levels that are normal during the month, but it's not sustained high. Whereas if you have a sustained high level, a very high level, then it probably does it probably does have health risks. So breast cancer, cancer of the womb lining, and increased risk of blood clots. And also some women feel when the estrogen levels are high, they can feel a bit anxious, have some palpitations, and actually it can cause hot sweats. So it doesn't happen very often, but it definitely is something to consider.
So I guess, how would I know then as a patient? There's a question in here then around what's the right level, what's the right dosage for me to manage my symptoms. So it's like Goldilocks, isn't it? Not too much, not too little, it's just right.
Yeah, so within standard doses, it's pretty predictable what the blood levels are going to be. So in terms of what's the right level for you, we can't predict that with a blood test. It's generally starting at either a low or a standard dose. So for example, a low dose of gel is 1 pump measure a day, a standard dose is 2, or a 25 microgram patch is a low dose patch, a 50 is a standard. So you usually start low or standard depending on symptoms, and then give it 6 to 8 to 12 weeks to really work out how you feel. And then you're in a good position to think, right, are my symptoms controlled? Yes or no? If yes, brilliant, that's the right dose for you. If no, you need to go back to your doctor because you probably need to tweak the dose.
Yeah, it really is. And certainly my experience has been as well. It's a bit of trial and error, but it's worth persevering with to get it right.
It is. And if you're at the sort of maximum standard dose, so 4 pumps of gel, 100 microgram patch, say, and you're still having hot flushes or not feeling yourself, not feeling right, then that's when I would then measure the estrogen level, just to make sure that you're absorbing properly from the HRT, because some people don't absorb brilliantly.
Yeah, and then that links to one last question on estrogen, Claire, and then we move on to the progesterones. Another great question here. What's the best way to find which treatment you need? This person's GP wants to look at their blood test results, but they've heard that they're not the most helpful. So her question is, how best can you identify what your body hormone levels are? So there's probably multiple things wrapped up in that, but what are your thoughts on that as a clinician?
In terms of the best HRT for you, I wouldn't necessarily go by blood tests. I would go by what you feel that you'll use every day. You know, I would not swallow a tablet. I know I forget, but somehow I remember to use the gel every day. Some people don't like the gel. They quite like the thought of a patch. Some people don't like the thought of something stuck on them. If the blood test showed that it's likely that you're still in the perimenopause, so say your estrogen levels are actually okay on that snapshot of the time of the day that you had the blood test done, then I personally would probably start a lower dose of estrogen, thinking, well, you've got quite a good level, but maybe your troughs are deeper. So maybe you just need a little bit to keep you on the straight and narrow. The other doctors may do it differently. That's what I would do. Yeah. So yes, quite a few factors. Yeah. Yeah.
Brilliant. Thank you, Claire. And then I think we've got some more questions in here, which we'll come back to because they relate to other questions that we will come to. So I suggest, Claire, if we maybe move on then. I know you're going to talk about progesterone next, and the different types of progesterone and why it's needed.
Yeah, so we've spoken about estrogen. Now, if you haven't had a hysterectomy and you still have your womb, and if you had a hysterectomy for endometriosis, but we'll talk about that later, you need a hormone called progestogen. Progestogens are the class of hormones, and that's because estrogen thickens the womb lining. So if you take an estrogen by itself over long periods of time, it can significantly increase your risk of cancer of the womb lining because the estrogen causes it to thicken and thicken. So you have to take a progestogen alongside the estrogen if you still have a womb. And this can sometimes be the challenge. So you can have patches that have the estrogen and progestogen mixed together. This is a synthetic progestogen called norethisterone. This is an Everil Conti patch, but Everil Sequi has the same patches within it. You can swallow progestogen in its body identical form, progesterone, in eutrogestin capsules, which you can see here. They're small round capsules. They have got gelatin in the capsule, so if you're strictly vegan, it may not be the best choice for you. You could have the progestogen in Mirena coil, which when I suggest it, often women immediately say no, but actually it's a really great way of keeping the womb lining thin and provides contraception. It's a little T-shaped bit of plastic that has a tiny amount of synthetic progestogen impregnated within it, and it just sits in the cavity of the womb there. You put it in folded up and then release it. So vagina here, cervix here, and womb here. Or you can have it in a combined tablet. So again, probably a really convenient way, just swallowing a tablet every day.
So Claire, some very interesting questions here on progesterone and progestrogens again. So a very practical one. If you cut the patches to in half to reduce the dosage, do you have any recommendations on where to cut to do that?
On a practical point, because they generally come with a half backing, if you cut it 90 degrees to the backing, if you cut it down the middle, it'll be a real fiddle trying to unpiddle it. So I would cut it half, but 90 degrees to the backing split, if that makes sense.
Yeah, super, thank you. And then another question here from somebody who's just started HRT. The 2-tablet progesterone, eutrogestin, taking 2 every night was very strong. Is it dangerous to take just 1 tablet of progesterone instead over a 2-week period?
Yeah, so that's a really great question. So if you start HRT when you're still having periods, it's advisable to take the type of HRT called sequential that still gives you a monthly bleed. It's not a period anymore, it's a withdrawal bleed from the hormones. And that means that you take the progestogen just for half of the month. So if you're using eutrogestin, which is the body identical progesterone, the standard dose is to take 2 capsules for 12 nights for half the month. And if you, it is advisable to take the recommended dose, because we know that that is the dose needed to keep the womb lining thin and stable. If you feel that dose is too high for you, I would have a chat with your doctor, because different women have different risk factors of their own for thickening of the womb lining. But something that you can do with eutrogestin is use it vaginally off license. So you literally put 2 capsules into the vagina with your fingers. You can get a pessary as well. And the eutrogestin is absorbed through the vaginal circulation, and it can be better tolerated that way. The other thing I would say about eutrogestin is it does settle. So if you start taking it and you think, oh, I feel a bit moody, a bit premenstrual in the first 1 to 2 to 3 months that you're taking it, those side effects do generally settle. So it just might be worth a chat with your doctor, but I wouldn't recommend just taking one for half of the month, because it might not be enough to keep your womb lining thin and stable.
Thank you, Claire. And then if we do last question here, progesterone, and then we'll go on to speak about vaginal estrogens and testosterone. If you is the Mirena coil the only option if you have thickening of the lining of the womb, or is there another form of progesterone that you can take?
If you already have thickening of the womb lining. So if you've been diagnosed as having endometrial hyperplasia or thickening of the womb lining, the Mirena is by far the most effective way of keeping it thin. If you really didn't want a Mirena, you weren't tolerating it, then you can take other oral synthetic progestogens, for example, Provera, separately, which might be effective also. So there will be alternatives. There's always another option, but this is the best option.
Thank you. And then one last one on progesterone. It's a good general question on it. Does the progesterone element of HRT increase the risk of breast cancer?
Oh, brilliant question. Yes, yeah, no, we do think that the risk of breast cancer is tied in with the progestogen. So if you've had a hysterectomy, estrogen-only HRT, little or no increased risk of breast cancer for women in their 50s over 5 years. Body identical progesterone plus the estrogen in whatever form has, again, over 5 years, minimal increased risk of breast cancer diagnosis. Whereas if you have a synthetic progestogen, for example, in some of the tablets and probably in the progestogen in the combined patch as well, there's a marginally higher risk of breast cancer. The risk is still really low. The risk of breast cancer being less on HRT than drinking a glass of wine a night data is based on old synthetic HRT. So, you know, the risk, we're talking marginal differences. But if you were worried about that, or you've been told that you were at high risk of breast cancer, you're better off having the Utrogestan. The risk with a Mirena is not zero, but it's minute because you hardly absorb any of the progestogen from the Mirena.
Brilliant, thank you, Claire. And then one last one on side effects, and then we'll definitely move on. This is a great question. The reason I'm calling it out, because I know you get this a lot, is one of this person's worst symptoms is migraines linked to the cycle, which worsened in the perimenopause. She's been given, I'm probably pronouncing this wrong, Claire, desogestrel.
Oh, desogestrel,
instead of the usual type of HRT. So do the different forms of progesterones act in the same way in the body?
So I wonder if they've been given desogestrel as HRT. Desogestrel is the progesterone-only mini pill, the contraceptive pill, and it is quite a good way of stabilizing some of the hormonal fluctuations that you get in your cycle and in the perimenopause, but it's just progestogen. You wouldn't usually, and I'm stressing usually, you wouldn't usually give the mini pill by itself to protect the womb lining. There's so many factors to consider, aren't there? If you've got migraine, stabilizing all hormones is usually the best option. So, for example, you could have desogestrel to try and do some stabilizing. You can have then Utrogestan, because it's known to keep the womb lining thin, and then you could have your estrogen in a patch. And that's a nice, really stable way of delivering the HRT. I personally wouldn't give one desogestrel by itself to keep the womb lining thin. I might give two off license, but your doctor may be considering other factors. It's difficult to say without knowing the exact history. But in the same way, a Mirena is really good if you have migraine as well, because that again will stabilize the progestogen with some estrogen in patch form to stabilize the estrogen. I hope that's answered the question. Sorry, it's hard without knowing the details.
Yeah, I know the details. So a general question, I think you've covered this, maybe a quick recap, the difference between progestogen and progesterone.
Yeah, so the progestogen is the sort of class of hormones, and progesterone is body identical, is one of the body identical hormones within that class of hormones. It's like, I can't think of an analogy off the top of my head. That progestogen is the umbrella term, and that would include progesterone, it would include norethindrone, medroxyprogesterone acetate, the desogestrel in the mini pills. So like estrogen is the umbrella term for the 3 different types of estrogens in the body.
Brilliant, thank you, Claire. Now on to vaginal estrogens.
Okay, so vaginal estrogens you can use alongside HRT or by themselves for vaginal symptoms like dryness, soreness, itchiness, painful sex, and also bladder symptoms like urgency. So you can have it in cream, which comes with an applicator, which you may or may not want to use, or you can use your finger. The cream is thick and white. And that's nice because you can use it with your finger. You can swish it around the inside and the outside. It's useful if you're losing that stretch at the entrance of the vagina. There are Vagifem pessaries. So you can see that tiny little pessary there on the end. So this is Vagifem. They come in these little plastic applicators. You put this into the vagina, press a little button and release the pessary. There is a brand called Vagirux where you only get 1 or 2 plastic applicators rather than a new one. So it's just a bit more environmentally friendly. And you can now buy this over the counter. It's called Gina. It's about £30 a box, but it's exactly the same as Vagifem or Vagirux. These are good, no mess, minimum mess. There's another pessary, which is a bit bigger, a waxy bullet called Invagis. That's quite good because it melts and gives a lubricating residue, but it's bad because it melts and you can get an oily discharge on your underwear, or if you're horse riding. I spoke to somebody the other day on the saddle, which wasn't great. And then there's a gel, Blissel gel, which is just a clear gel. And this is quite good because it's a lower dose than the Ovestin cream. So, and oh, finally, nearly forgot. There's a ring that sits inside the vagina. You squish it up, insert it. It looks quite big, but actually the vagina is very stretchy generally. And that releases estrogen the whole time. So they're quite good if you don't like the faff of using different products.
And how often do you have to replace that, Claire?
So every 3 months.
And can you do it yourself, or do you need your doctor?
Yeah, well, usually I fit the first one, and then if women are comfortable, you know, it's easy to remove. You put your finger into the vagina, hook it down, and then put another one up. Some people don't like to, other people are fine. You can have sex with it in, and it won't make your man grow boobs.
I'm sure it's a question in everybody's mind, Claire.
Please,
particularly your partners.
I'm
not surprised, Claire. I'm not surprised. I can understand why people would ask that question. So moving on then to testosterone, the third hormone.
Yeah. So some women choose to add testosterone then for mainly low libido is where the best evidence-based is. Some women also report that it helps cognitive function, sharpness, and memory and mood and marginal energy, but the best evidence is for libido. So testosterone, privately only, you can get Androfem, which is licensed for women in Australia. This comes with a little syringe and you suck out pea-sized amount, something like that, and then you rub it again front of your thigh. You can put that on your lower tummy and you just massage it in every day. This is quite expensive. It's between 80 and 100 pounds a tube that will last you about 100 days. Privately or on the NHS, you can get little sachets of tester gel, and you make that little sachet last around 8 days, depending on the preparation that your doctor is able to source. Or I don't have any, but there is a pump called Tostran, which is a stronger 2% gel, where you would use that every other day and rub it again to your thigh. Testosterone can take up to 6 months to work. People really worry about the side effects, obviously, but in reality, most women don't have side effects. The odd extra spot, if you are prone to acne and rosacea, it can just sometimes trigger it. The odd extra whisker on the chin is quite common. Change in body odor.
And then do you need to take blood tests or anything, Claire, if you've been prescribed testosterone?
Yeah, so I follow guidelines and I check a testosterone before I start it, just to make sure that the level isn't raised, basically. There's really poor correlation between the level and symptoms. So we just check it to make sure that you don't have too much of it already. And then we check it somewhere between 6 to 12 weeks and then annually after that.
Okay, brilliant. Thank you. And can you take testosterone on its own, so without taking estrogen? So if you feel that that's the only symptom that you have?
Yeah, so libido is very bound up in the estrogen as well. So I only in absolutely exceptional circumstances would I prescribe testosterone by itself, because if you give it by itself, the evidence is that most of it is converted to estrogen anyway. So the guidelines say to give it in women who are already on HRT, who are well estrogenized. So okay. I would only in really exceptional circumstances.
Yeah, and then I know we'll touch on this later, but while we're talking about loss of libido here, if you don't want to take testosterone, what advice would you give to somebody who's suffering from loss of libido? Because it's a really great question, isn't it?
It absolutely is. And I wondered if we could post the link to the 2 webinars that we ran. It's such a complicated question. Libido is so sensitive that it would be a combination of making sure there's nothing physical spoiling your enjoyment of sex. So if you have any bladder symptoms, any vaginal symptoms, treat them. Talk to your partner, talk to them about what's happening for you. See if you can pinpoint also why your libido's low. You know, are you having hot flushes? Is it all the other symptoms that are really making you feel really rubbish? And that's having an impact. And then, as I said, the communication, the sex therapists that we've done events with have said, you know, long-term relationships, particularly often, you need to go back to the drawing board a little bit. So that's a very superficial answer, but we've got more information on the website.
Yeah. So Emma, if you could post a link to that webinar, the 2 webinars that we've done on this, and just so everybody's aware, it was with Dr. Clare, but also 2 sex and relationship counsellors, both named Sue, rather confusingly, but a different Sue, both brilliant women. And Eleanor Gardner from Pelvic Relief, where we also spoke about the various devices and gadgets that you can use to ease pain, but also to spice things up.
Yeah, no, absolutely. And I should have said, that's reminded me, vaginal lubricants and moisturizers, really important. So Eleanor would talk, she's an ambassador for the Yes Yes company, who do, there are a plethora of other ones out there, but super important. Yeah,
and we've got some great shorter videos, Emma. Maybe we can post those as well on the best sex toys and lubricants for sex during the menopause as well, because, you know, that's why I thought it was such a great question, because there are other options out there. So Claire, we spent a lot of time looking at the different types of HRT and really started to get into the benefits and risks with them. But I wonder if you could maybe just step back and help us to understand the benefits of HRT more broadly. And while you're doing that, Emma, if you could also post into the chat a link to the symptom checker, because some of the questions coming up are about around solutions to different individual symptoms. And we cover 40 different symptoms of menopause in the symptom checker, with Dr. Clare's brilliant advice on the range of things you can do, not only HRT, but also including HRT within that. So Claire, over to you on the key benefits to taking HRT.
Yeah. Thanks, Helen. So the most basic benefit is management of symptoms. For most women, not for everybody, for most women, it will be the most effective way of managing menopause symptoms. It won't make everything completely go away, but it will usually help you make that transition more positively. There are long-term health consequences to the menopause. So when we lose estrogen, we increase our risk of heart disease, we increase our risk of osteoporosis and fractures. And for younger women, so women going through the menopause under the age of 40, we also know that the risk of dementia can increase also. So HRT, we know, decreases the risk of osteoporosis and fractures. It helps build good, dense bones, keeps your bones strong. HRT, if you start under the age of 60 or within 10 years of the menopause, it significantly reduces your risk of heart disease and heart disease related deaths. And if you're a young woman going through the menopause, then there is good evidence that HRT helps prevent dementia. If you're going through the menopause around the average age, between 45 55, the evidence isn't as clear. We don't know that it definitely does reduce the risk of dementia, but certainly it's clear for young women. So they're the main benefits. Brilliant.
And then that is really, really clear, and particularly in terms of post-menopausal health. And that leads always to a couple of questions. Another great question in here, Claire, is from somebody who isn't particularly struggling with symptoms, but wondering if they should take HRT for the longer term health benefits that it can bring.
Yeah, it is a really good question, and it's surprisingly complicated to answer, and it really depends on you as an individual. So the British Menopause Society, the International Menopause Society don't recommend use of HRT purely for disease prevention in the absence of symptoms. And that's because although the risks are tiny, the risks aren't zero. But having said that, the benefits of HRT statistically do by far outweigh those really small risks. So it's so difficult to generalize. I say it's an individual decision for you, looking at your lifestyle, looking at your risk factors, to decide whether you want to take HRT, because some women do have side effects to HRT. Some women don't get on so well with it. It can take a few tweaks to get the right HRT to manage your symptoms. So yeah, I think it's a really individual decision.
Brilliant, thank you, Claire. And then a couple of questions around symptoms around mood and cognition. So somebody's asking, if estrogen can help with brain fog. So I think you've addressed that. And again, if you look at the symptom chapter, but again, another really interesting question around knowing the difference between, say, clinical depression and menopause-related depression. And is HRT the right solution, or antidepressants, or a combination?
Yeah, that's a really good point. So if you have low mood, depression, anxiety that is related to the menopause, then the evidence is that probably HRT is better at managing, or more effective way of managing it, than antidepressants. But if you do have really severe depression, really severe anxiety that we'd class as clinical depression or anxiety, it may be that you need some the addition of antidepressant as well as HRT. For some women, it may be that they need an antidepressant, particularly if you've got a history of depression and then you have a really big dip as a result of the menopause transition. Again, it may be a combination of HRT and antidepressants that are needed. But certainly if you've got symptoms suggesting low mood, symptoms of mild to moderate depression, if you've got anxiety that comes out of the blue in the menopause, in the perimenopause, then it's likely that HRT is going to be more effective.
Yeah, thank you, Claire. And again, I suppose linked to the broader use of HRT, a very timely question here in terms of how long should you take it for, or how do you know when to stop, should you stop?
Yes. Yeah, I know, it's so difficult to know. So the menopause, as I've said, is a transition, and your body is adapting to its new normalness of a low level of estrogen. And taking HRT doesn't stop it adapting. It doesn't press the pause button on your transition. So that's the first thing to say. So I would say that there's no time limit. There is no arbitrary cutoff time that you have to stop HRT by or at. So, excuse me, in the olden days, I know women were told they could only take it for 5 years, or they could only take it till they were 60. But in reality, there's no arbitrary cutoff. You can take it for as long as you want to, as long as you understand the longer you take it for, the increase the risk of breast cancer is. So the risk of breast cancer is related to how long you take the HRT for.
Brilliant, thank you, Claire. Do you want to grab a drink of water, and I'll just call out what we're going to cover next?
Quick slurp of tea.
I know it's lots to cover. So before we go on to the risks and the side effects of HRT, a last one, a question that came in advance from someone who's under 40, has always had irregular periods. She's worried that she might have premature menopause, POI, as her periods have been less and less regular, and she has some perimenopausal symptoms. You've already called out the importance of taking HRT, but I suppose her question is, and the reason I'm asking you, because it's such an important question for this person, what's the best way for her to get a diagnosis to see if she has a premature menopause?
Yes, go and talk to your doctor, and specifically bring up the menopause as well as a possible, as something you're worried about. You can do blood tests. If the blood tests are normal, a bit like women in the perimenopause at an older age, the blood test might be normal and you could be in the perimenopause at a younger age. But I would start with hormone blood tests and blood tests to rule out other causes to your symptoms as well. And then it may be that you need a referral to a specialist menopause clinic. It may be that you don't, depending on your GP and what they find. But start with blood tests and start by asking the question, could I be in the menopause? Because sometimes, with the best will in the world, it's not thought about as a potential diagnosis for younger women, which is not right. It should be on the list of many different differential diagnoses. That would be my advice.
Yeah, thank you, Claire. That's really clear. And then we also have the free menopause questionnaire on our website that you have designed, that gives people a personalised assessment of if and where they might be in the menopause transition. So for anyone on the call who has questions about their symptoms, if you take that questionnaire, you get a personalised email, and it'll link you through to all the relevant articles and the information that we have about symptoms and treatment options. So Claire, we've got about another 15 minutes left, and there's lots to go through and lots of questions still. So maybe if we cover very quickly, maybe the risks of HRT and the most common side effects. And Emma, if you put in the link again, maybe to the resource article that we have into HRT, because Claire covers all of that in detail in that article. So you can all read it at your leisure after the webinar this evening.
So in a nutshell, risks of HRT: if you swallow estrogen, it probably approximately doubles your risk of blood clots on legs, lungs and stroke. In reality, if your risk in your 50s, if you're fit and healthy, is something like 3 or 4 in 1,000, doubling that just gets you to 6 to 8 in 1,000. So the risk is still very low. The risk of breast cancer we've spoken about, it's very low. Not to dismiss that risk though, or the impact of having a diagnosis of breast cancer. The risk of taking HRT is lower than having a glass of wine or 2 units of alcohol a day. And if your body mass index is 30 or above, that more than doubles your risk of breast cancer. Still, we're still talking small numbers. There's an association with ovarian cancer where the longer you take HRT for, the higher the risk of diagnosis of ovarian cancer, of approximately 1 extra case per 1,000 per year, but no causal link has ever been proven. So it's on the leaflet, but it's in reality a tiny risk. the leaflets for the packet in the packets for HRT are, have the risks of quite a few older studies swallowing estrogen, so they're quite scary to look at. They talk about the risk of heart disease and sometimes dementia, but I think the latest data with the types of HRT we're prescribing now, we're pretty clear that HRT doesn't increase your risk of heart disease.
Brilliant, thank you, Claire. So looking at the most common HRT side effects, and I suppose linked to that, how long should you give the side effects to settle down before going back to speak to your doctor?
Yeah, and that's one of the reasons I often start with a low dose and work up. So the most common side effects are when you first start HRT out of not taking any, you can feel a bit discombobulated, a bit odd, headachy, breast tenderness. Breast tenderness is common, bloating is common, fluid retention. Some women feel a little bit sick. Some women feel a bit moody with the progestogens, a bit premenstrual. And Eutrogestin can be a bit like Marmite. Some women don't like taking this because it really affects their mood. The numbers are small and there are ways of tweaking it so it's better tolerated, but they're the most common side effects, and they would generally settle relatively quickly, usually within the sometimes first few days, maybe first few weeks. Breast tenderness is one that can linger, I have to say, particularly with estrogel, and that can come on sort of a bit out of the blue as well, a few months down the line. So that's probably the most bothersome one, apart from mood changes with the progesterone. It's not uncommon to get a bit of bleeding, unscheduled bleeding when you start HRT, and that generally settles. If it settles, it's usually nothing to worry about. But if the bleeding was after intercourse, if it's very heavy, you should definitely talk to your doctor about it.
Super, thank you, Claire. And then you've actually touched on a lot of the myths already around HRT, and Emma has very kindly, thank you, Emma, posted a link to a blog and some articles on HRT myths as well. But just a couple that are worth touching on, I think. There's a question in here in advance: will hot flushes and other menopausal symptoms return when I come off HRT? So it's linked to that question around, does HRT delay the menopause or symptoms?
Yeah, I know. It's a big worry. Generally, no. So because the HRT doesn't pause your transition, and we don't know how long you're programmed to have symptoms for, you won't know how you are going to feel until you stop the HRT. So say you take HRT till 60, there's no way of knowing whether your hot flushes have settled until you stop the HRT. If you stop the HRT and in the background your body is adapted, hot flushes have settled, when you stop HRT, you won't have any significant hot flushes again. But if you're unlucky and the hot flushes are still rumbling along, your body hasn't adapted to the low estrogen, when you stop the HRT, you'll just whoosh, get the hot flushes back again. And possibly, going back on HRT then is definitely an option.
Yeah, okay, brilliant, Claire. And then on the other side of it, I suppose somebody here who took HRT for symptoms but found it made her feel worse, and so she came off it and felt better.
Yeah.
And she's now feeling pressure to take it again. I suppose just given the level of coverage about HRT in the media, would she be okay in the long term if she doesn't go back on this? I know.
Yes, yeah, no, completely and utterly. So even though we talk about the risk of heart disease increasing after the menopause, the risk of osteoporosis, there is lots you can do to negate that risk by healthy eating, exercise, not smoking, not drinking too much. You shouldn't feel pressure to take HRT. I do think it's a really individual decision. The only thing I would say, if you want to take HRT and it made you feel worse, I would go back to the drawing board and try a different type of HRT, but don't feel pressure that you have to do it. It's something I'm increasingly hearing in clinic, actually. You know, what am I missing out on if I don't take it? You know, I feel like I should, but I don't really want to. Well, it's your body, you know,
your body, your choice.
Exactly. Yeah.
Yeah, brilliant. So Claire, we're going to, this really is the mastermind moment, rattle through some questions. I know you get a lot from patients, and we've got these in advance, and as well, they've also come up in the chat. So this is one I know you get a lot. How bad should my symptoms be before starting HRT? And one literal quote was, should I just man up and get on with it?
You don't have to wait. There's no scoring system. When your symptoms are bothering you, go and speak to your doctor. And if you want to take HRT, take HRT. You don't have to wait till you're not sleeping or, you know, thinking like you need to resign. Or
in a desperate state, which unfortunately, you know, stoicism is there are no prizes for being stoic, is there, in this?
No badges of honor.
Yeah, no badges, definitely. And then I suppose linked to that as well, can you take HRT while you're still having periods? Or do you have to wait? Again, great question, because some GPs have a different view, don't they?
Yeah,
the expert.
Yes, I still hear the GP said I had to wait till my periods have finished for a year. No, you can start HRT while you're still having periods. That's the perimenopause. If your periods haven't stopped, you just need what we call sequential HRT, or if you're fed up of having periods, have a Mirena fit and have the estrogen alongside it.
Yeah, brilliant. Thank you, Claire. Again, we've kind of touched on this, but short question, can you be too young or too old to take HRT?
No, absolutely not. For much older women, there's a bit of a black hole of evidence confirming safety, but it's not likely to be a risky thing to do. So, and at the other end of the spectrum, if you're a young woman in the menopause, you really need HRT. So you can't be too young, can't be too old.
Yeah, good. And I know in the FAQs, we have a specific piece around taking HRT over the age of 60, because I know that was a question that came in, but I know you have women in their 70s and 80s, Claire, in the clinic who are still taking HRT for hot flushes, I think.
Oh, completely. And I was speaking to a colleague the other day, and she'd had a lady age 89 still having hot flushes, and for the last few years of her life did not want her hot flushes, so started HRT. Yeah, brilliant.
Thank you. How long generally, quick recap, do you need to take HRT to see the benefits? And this person who wrote in as well, linked to that, having really poor sleep because of night sweats. So how long should she wait before going back to speak to her doctor?
If it hasn't touched the night sweats, I wouldn't wait 3 months, which is like the magic number that is bandied around. If your hot sweats haven't been helped and it's sort of 6 weeks down the line, I would go back.
Yeah, brilliant. Thank you. And can you take HRT after 5 years?
Yes.
Okay, I'm touching that note. Good to be clear on that. Can you take vaginal estrogens when you're taking other forms of HRT as well?
Completely, and a good percentage of women need both, particularly if you're on a lower dose of systemic HRT, so like gel, patch, etc. Many women need a vaginal estrogen as well, and you're not going to get too much estrogen by doing that. It's fine. You hardly absorb anything from the vagina.
Yeah, brilliant. And then, are there any particular conditions that mean one can't take HRT? And a specific question from somebody in advance saying that she's diabetic and she's heard that HRT will increase blood sugar. Does that mean that she can't take it?
No, it's the other way around. So it does depend on the type of diabetes. So if you're type 1 diabetic, then you can take HRT. It's not risky. If you're type 2 diabetic, actually, HRT has been shown to help increase marginally blood sugar control. So it's a good thing to do. You can take HRT if you are diabetic, and in reality there are very, very few conditions where you absolutely can't take HRT, and it's usually around the estrogen dependent cancers like breast cancer, and even then it's a very individual decision. You know, it's not clear cut. You might be able to, depending on how bad your symptoms are and the risks that you're prepared to take.
Thank you. Then we've had a question that was submitted in advance. It's quite detailed, but I'll ask the key question, Claire. At what point should this person move from sequential to continuous combined progesterone? She's taking 3 pumps of estrogel, 2 eutrogestin capsules vaginally for 12 days every 28 days, a pump of testosterone and testosterone gel and inner thigh, and Ovestin cream. So taking quite a lot. So her question is about the next step and when she should move.
Yeah, so from memory, she'd been using sequential HRT for 2 years, and that's the progesterone for half of the month. So the rule of thumb is you switch to a no bleed continuous regime after a maximum of 5 years on sequential, or when you're 55, whichever comes soonest. And the reason 55 is used is because that's when the vast majority of women will have stopped their periods. Not everybody, but the majority of women will have stopped their periods at 55. So whoever asked the question, so in probably for another 3 or 4 years, sorry, can't do sums, for another 2 or 3 years, if you've been on sequential for 2 years, you've probably got another 2 or 3 years on sequential before you switch. Occasionally, women stop having the withdrawal bleed on sequential HRT, and then you can switch sooner because it's that lack of bleed is telling you that the estrogen level is very low. But some women do just continue bleeding, whatever the estrogen level is doing in the background.
Okay, thank you. And then someone here has had symptoms for around 12 months, and the doctor has recommended just a Mirena coil, and they've also been offered antidepressants on numerous appointments. Her question is, should she be pushing for estrogen as well?
Yeah, so the Mirena coil will stop periods for the majority of women, but it won't help your mood or anxiety related to the menopause. So I would push for some estrogen as well. That there may be a reason your GP is offering antidepressants if your symptoms are really severe, so it's worth just questioning what their thinking is, but don't be afraid to push for some estrogen alongside the Mirena. It might be worth asking in your practice who the best menopause GP is. Yeah,
brilliant. And linked to that, somebody's asked the question, how do I have a conversation with my GP when they're not very knowledgeable about HRT? I suppose hopefully after this evening, you feel more empowered with information to go speak to your GP and use the resources on our website. Any other thoughts, Claire? Because it can be tricky for people.
I know, try a different GP, ask around who the best GP is, or just go having had a read and just, I know it doesn't sound right to be suggesting things to your doctor, but don't be afraid to suggest things to your doctor.
Yeah, thank you. That's great, Claire, and so important. You've got to back yourself when you go speak to your doctor. You can do it very politely and nicely, but back yourself. Last couple of questions. This lady told by her doctor to take eutrogestin every night, 100 milligrams to help with anxiety. Your thoughts on that?
So no, absolutely. I would want to know if your periods have stopped though, and whether you're taking that alongside estrogen. Eutrogestin can help anxiety by itself, but I'd need a bit more. It's probably absolutely fine. Are you taking it alongside estrogen as HRT? Have your periods stopped? You know, they would be the questions I would be wondering. So yeah. You have to sort of be guided by your doctor with your personal circumstances.
Okay, it's so important to understand that. Then Claire, if we could just touch on the question we got from the lady with endometriosis who's had it surgically removed. I won't read the whole question out, it's quite long, but her question is really, is it safe for her to take Cerazette to manage the adenomyosis, if I pronounced that right again. I know you've guided me on it. And also the estrogen gel and eutrogestrone to manage perimenopause symptoms.
Yes, absolutely. So you can take the desogestrel mini pill, which can be really helpful in managing adenomyosis, which is where the lining of the womb grows into the muscle and causes heavy, painful periods, alongside eutrogeston to keep the womb lining thin, and then the estrogen to help manage your symptoms. That's absolutely fine. Women get worried about HRT and endometriosis, but in reality, as long as you're cautious with the dosing of estrogen, it rarely causes an issue. So you can have HRT if you have a history of endometriosis. Just need to be careful about the dosing.
Thank you, Claire. And then we've had, this is the first time I think having this question, and this is the last question we'll take, and then a quick word on alternatives to HRT. This lady's husband makes her wonder if her erratic behavior and inability to focus on one thing, if it's ADHD, and she's just wondering, is there a relationship between menopause and undiagnosed ADHD?
Yeah, no, that's a really interesting question. And I know we've got an event coming up with a psychiatrist with an interest in ADHD. So I was having a chat with him. He was saying that menopause symptoms and ADHD symptoms do overlap. So the brain fog, the difficulty concentrating, for example, and ADHD type symptoms, ADHD can worsen in the menopause transition. And women who are on HRT and the hot flushes have settled, you know, generally feeling better, but still have those specific cognitive symptoms to a bothersome level, could be, there is a possibility it could be ADHD. So it's worth talking to somebody with an interest in ADHD. It's a really good question to ask. And we will have more information on that coming up and on our website.
We'll be doing that. We'll be doing an event in the new year with Dr Clare and her colleague. So I'm afraid that's all the time that we have for questions. But last question then, Claire, for you. We said we'd talk about very briefly, prescribable alternatives to HRT. So for women who can't or don't want to take HRT, and Emma has posted into the chat the link to the event that we did earlier in the summer, where we were joined by two fabulous people to speak about acupuncture and herbal supplements and how they can help as well. So I'd guide you to that and to the blogs for that. But on prescribable alternatives that are used, so in conventional medicine, Claire, what are the key ones that you and your fellow menopause experts would recommend?
Yeah, so there is a list of medication that can also help menopause symptoms that isn't HRT. So clonidine is a blood pressure tablet that can help hot flushes and is licensed for menopause hot flushes. All of the SSRI type antidepressants can be helpful for some women to a greater or lesser degree. They act by boosting the serotonin levels in your brain, which the levels drop with the drop of estrogen in the menopause. So that's how they're likely to work. For some women, gabapentin can be helpful at night, particularly to help night sweats and sleep. There's a tablet that's usually used for bladder urgency called oxybutynin, where there's some evidence it can help hot flushes. I was reading the other day, actually, somebody had done a study on vitamin B6, folic acid, that had been shown to be helpful. And obviously vitamin D is good for helping support bone health. So there are a number of different options that your GP or menopause specialist can work through to try and help you if you don't want to or you can't take HRT. And then obviously, I know we've got information, but lifestyle is really important. So exercise or switching off, relaxing, talking therapies can be really effective as well, CBT. So yeah, it doesn't have to be a prescription medication. There are other ways of managing symptoms. Yeah,
that's brilliant, Claire. Thank you. And Emma, I think if we put into the chat a link to the HRT treatment options resource article that covers prescribable and lifestyle alternatives and also herbal remedies as well. So I think that we need to wrap it up there. Thank you so much. We've run over. I think, Claire, we could easily have spent another couple of hours going through all the questions. I know we got to as many as we could. Apologies that we didn't get to everyone, but hopefully between the conversation that we've had, listening to other people's questions, and the information that Emma has very kindly popped into the chat, hopefully that has helped you. I'm sure we will be doing another HRT event again in the new year. We always get so many questions and so many requests around HRT, and there's a real need for this information. So a big thank you to Emma, and a particularly big thank you to Claire on the back of a long day in the clinic to do the chat with us this evening. Really much appreciated, and thank you so much for empowering us all with a lot more information about a HRT. Thank you. Good evening, everyone. Take care. Bye-bye.
Yes, thanks, Helen. Bye, everybody.